Good evening, everyone. For those of you who don't know me, my name is Julia Leaf. I am the Executive Director of Cambridge Common Writers, which is a nonprofit organization designed to support and celebrate the writing successes and journeys of the alums of Lesley MFAs and Creative Writing Program at the Lesley University. And I am very excited today that we are celebrating the book launch of Rosalind Kaplan's memoir and essays, Still Healing. And Rosalind, that will be in conversation with Robbie Gamble, which is especially exciting because they were cohorts at one point during the program. And it's always nice when we have the opportunity to bring old cohorts together so they can talk about each other's work again. So just a quick introduction for the both of them, and then I'll hand things over. We have, sorry, just looking for the right file here. Rosalind Kaplan graduated from the MFA program in June 2020 with a focus in nonfiction. She is a Philadelphia-based writer of narrative medicine, memoir, and personal essays, as well as a physician and teacher of narrative medicine. Her work can be found in another Chicago magazine, the Eastern Iowa Review, Brandeis Magazine, and Prompted, a Philadelphia Stories Anthology, among others. Her memoir and essay, Still Healing, offers a glimpse into the complicated world of being a doctor and the American healthcare system. Robbie Gamble thought Lesley MFA's program was so nice he did it twice, graduating with a focus in poetry in January of 2017 and nonfiction in June 2020. His poems have been published in the American Journal of Poetry, Carve Magazine, the Lilly Poetry Review, Rust and Moth, among others. He was the winner of the 2017 Carve Poetry Prize and has had poems nominated for Best of the Net and the Pushcart Prize. He is the poetry editor for Solstice, a magazine of diverse voices. He and Rosalind were nonfiction cohorts and bonded over their shared medical backgrounds. So I will hand things over to them. And just so you all know, if you have any questions during this event that you would like to ask Rosalind, we will have a little time at the end for Q&A, but you can also just drop them in the chat and we will ask them later on. So without further ado, I will hand things over.
Thank you, Julia. And if you want to put in the if you want to put in the chat the link to the book too, that would be lovely. It's I'm thrilled on so many levels to be able to be in conversation with Rosalind about her book. Partly because when we were both at Lesley, in workshop, I saw some of these essays in process, and it's really wonderful to see it now in its full book state. And it's a wonderful read. I'm also excited because I'm also a clinician. I'm a now retired family nurse practitioner. I worked for 20 plus years for Boston Healthcare for the Homeless Program, and so this book just resonated with me on so many levels. The intersection between healthcare and clinical work and storytelling and trying to find ways to write about the things that we've experienced is really something. So I'm really looking forward to having a conversation with Rosalind and to hear you read some excerpts from the work. And so maybe we'll start there. I know, Roz, that you have there's a couple of sections that you thought might work really well for launching this book. If you want to go ahead.
Yeah, thank you, Robbie. Before I read, I just want to say thank you to Julia for all the work that she put in to get this going, and thank you to Robbie for reading and attending to this and considering what we might talk about around these essays. So this book, Still Healing, is sort of memoir and essays. And I'm going to start with reading an essay called War Stories, just as a way to sort of get us into the material. We tell war stories, we doctors do. Like veterans, we talk about our most harrowing times, the worst nights on call, the time we stayed awake, working, keeping someone alive for 36 or 42 hours at a stretch, the time we almost died driving home because we couldn't stay awake any longer and nodded off at the wheel. We commemorate the most gruesome gunshot wound we saw as a student, the youngest patient we lost in a code blue as a resident. 3 or 4 decades may have gone by since the events we recount. Still, we will find an opportunity to bring up the time the attending threw a scissors at us in the OR, or the time blood started spurting out of our patient's esophagus, splattering the ceiling of the ICU. When we get together in groups, the tales are told on endless replay. Remember that patient with the maggots in her bed sores? The drug addict who shot heroin in his central line when he was on my watch? We like to talk about our intimate relationship to the brokenness of our fellow humans, of the system, of equipment, of the world. I say I'm proud of the night I took a 10-year-old bullet out of a man's leg in urgent care. It was eroding out through his skin, pus surrounding it. We were in the first weeks of the pandemic, and the ERs were packed with COVID patients. So I did something I wouldn't ordinarily do without the equipment and the backup of the hospital. Everyone talked about it. For a moment there, I was badass, a cowboy, a renegade. It made me seem more interesting than I really am, an aging, nerdy doctor of internal medicine, a woman who would rather read a novel than go to a party, and who can't handle more than one drink in an evening. What is it about the brokenness that makes us want to return to it over and over when we're together? Well, what are war stories after all, except the recounting of trauma? We act like our proximity to the brokenness makes us unbroken, whole, unbreakable. Like flexing those trauma muscles over and over makes them tougher and stronger. But isn't it really the opposite? The closer we sit to the brokenness, the more broken we are. We think that somehow all these terrible debacles make us more resilient. Look at all I've experienced. I shocked someone with a defibrillator 9 times in one evening. Look what I can handle. Look how immortal I am. But when I really let myself remember, when I go back to what it felt like then, I know it didn't bring resilience. I'm alone, the only doctor covering an interminable night of suffering at the cancer hospital affiliated with my medical training institution. A patient with lymphoma, now in kidney failure and heart failure after chemotherapy wreaked havoc on his body, has an arrhythmia. I know next to nothing about chemotherapy and less about the damage it's done to my patient's heart, but I'm well versed in the protocol for treatment of this abnormal heart rhythm. I begin instituting it, but I'm scared. I'm scared that I'm not going to get this right, that this man's chance at beating his cancer is going to end with my inexperience, my ineptitude, and that I'm going to inflict suffering rather than alleviate it. I'm sweating and cold at the same time as I inject medications into my patient's central intravenous line, and my hands shake as I apply the defibrillator pad to his chest. He's sedated, not consciously aware of the jolt of electricity, but his body jerks, and I imagine it registering in some deep animal part of his brain. After all the medications are in, and I've increased the voltage of the shocks, and his heart continues beating at an unsustainable rate, I page the cardiologist on call. Um, he tells me I must place a pacemaker if the next round of shocks doesn't convert the rhythm. I don't know how. I've only seen this done once, but he tells me I will have to. It will take too long for him to get to the hospital so he could do the procedure. He talks me through it on the phone. Once I get the pacer to capture, I should feel jubilant. I have saved a life, but I'm not. At first, I'm shaking and cold and numb. Then I reach the on-call room, lock the door behind me, and the nausea hits. I vomit and quake for the next half hour while ignoring a page from a nurse about another patient with a fever. All I want is to go home and never return, never have another night on call, never be responsible for another life. I'm not even ready to take responsibility for my own life. This night will stay with me and become a war story. This night and the night my patient bled to death in the radiology suite while I tried to force more blood into his dying body by squeezing the bag holding the packed red blood cells. These nights, the time a patient bit me in the ER, that patient and the needle stick injury that gave me hepatitis, all that, and the woman who screamed, "Fuck you," and spat at me 100 times because I wouldn't refill her pain medicines, and the man who had a psychotic break in my waiting room and smeared feces on the walls until the cops came and took him to psych crisis. Our traumas bind us doctors to each other, especially if we've been in medicine for a long time. You know, the residents don't even have to stay overnight anymore. They have work hour limits, but when I was a resident, we didn't eat or sleep or go to the bathroom for whole days. I hear this coming from my mouth, from the mouths of my colleagues, and I cringe. It's not that we want these younger doctors to suffer as we did. We lobbied for change. We want things to be better. We just need to return over and over to our own suffering and pretend one more time that we might be whole, unbreakable, badass, when really we're broken, broken down, tired, mourning. We lost the innocence that comes from steering clear of trauma until it comes to find you. Instead, we walk directly through trauma's door and let it lock us in. We need to return to the moments of trauma over and over, turn them around, see them with a different slant, as though the retelling might break the lock. Oh, you're muted, Robbie.
There we go. Yeah. Wow. I know. I'm even though I've read that passage so many times, but to hear you read it, I'm so stunned that I forget to unmute myself. Um, yeah, it's our intimate relationship with brokenness, and I think that's. I mean, you really put your finger on the pulse of it, and that's what really seems to carry throughout all of these essays throughout the book is that relationship. And I'm sort of struck with how you sort of swing from being vulnerable, from being badass to being but vulnerable, and um just feeling those feelings of inadequacy when you don't know what to do, um whether it's because systems are failing you or because the situation is just impossible, or I mean, and I mean, there's so many stories that you pull together. But what I'd love to talk a bit about, and sort of what you see is, is that juncture between medicine and storytelling, and why it's so important. I mean, the war stories are sort of the greatest hits of things, but I've always been at one point. I remember I was sitting in our team room writing up notes at the end of the day of all of the patients I'd seen, and I realized like most of what I do actually is storytelling, and most of the stories are really mundane. It's the patients that I saw that day, the soap notes that we write, where we just sort of say what we saw, what the patients told us, what we think is happening, and what we plan to do about it, so we can pass it on to the next provider. Um, but out of those sort of mundane bits that we do all the time come these sort of bigger stories that affect us deeply for the rest of our lives, or that we feel the need to share with a wider audience. And I wondered if you could just sort of talk about that for a bit.
Yeah, absolutely. I mean, when I teach about writing to medical students, one of the things we talk about, well, the sort of the first thing we talk about is, well, why is it that so many doctors write? And it's become like this huge thing. There's a larger and larger genre. Some of it is straight narrative medicine, but some of it is also fiction or memoir, sort of like this, or even memoir that's not so much geared to medicine. And some of it is, we say, yeah, medicine is that front row seat to the play of life. And we see a lot and hear a lot that other people just aren't privy to, because it's not the stuff that goes out there in even friendship relationships, except really deep friendships, that you don't really want to talk about on a day-to-day basis for all kinds of reasons, because it shows what's going on inside, both physically and emotionally. So, I think the stories come out of a lot of that. And I think one of the reasons that we like to write as doctors is to get some of that trauma stuff out of us. And, even if we don't admit that that's the reason, we're like, oh, wow, this is a really great story. Well, things stick with you. And I've always found that by writing through a situation that's been, that's really affecting me, I figure out through the writing why it is that it affects me so much, what it connects to for me. And I often like sort of come up with answers to that. And I also feel this great relief of having gotten something off my chest, so literally out of my body and onto the
Mhm.
page. I feel like it's a real catharsis. So that's one reason. And I think another reason is because, like all writers, we sort of feel like, well, there's stuff here that maybe other people want to know about. A
Mhm.
lot of people like to read about or watch shows about medicine. Like the recent show that everybody watched was The Pit, which was
Yeah.
so vivid, the ER scenes and all that. People want to know about things that they're not involved in. And since almost everyone has to go to a doctor or ends up in a hospital at some point, sort of knowing some of what's going on behind the scenes is really helpful. So some of it is putting it out there for other people too. Is that
Yeah, that's really true. Yeah, I think what you say about the process of externalizing something that you carry. I know I had a younger brother who died suddenly, too young, and you know, my parents both outlived him, and I remember, yeah, I felt like this is something that I need to write about, and I couldn't for a while. And when I finally did, I wrote this poem that I read at his memorial service, and it was both for me and for my parents. It was a thing that they could look at and say, like, there, that, see that thing there, that's how I feel, and I don't need to carry it, but I can show it to people, or I can have it, you know, I can have it framed and put on the wall, and it's sort of, it's there, but the burden is less. So I think that's a really important thing. And then also that the sharing of what's behind the curtain, it's really true that.
and I think the sharing of that burden when other people know what's really going on inside you, and you didn't have to verbally sit down and explain it to someone. You were able to put it on paper and share it that way, and they could digest it in whatever way they needed to, and whatever time they needed to, which is why I love to read, because I have my own time frame for how I sort of process all of that. Um,
Mhm.
I think that that sharing is helpful for both the person who's doing the sharing, but also the people around them, who read this stuff, and oh, now I understand why, he sometimes, seems like he's off in the distance or whatever. It gives them a
Mhm.
better understanding of you as a person. And I remember a lot of the things that you wrote when we were writing nonfiction, and you wrote things about patients that you saw. I remember one that really spoke to me. It was about addiction,
Mhm.
and a patient that you had been working with, and it seemed like there was something universal about it too. I mean,
Mhm.
most of us will encounter someone who's struggling with addiction, just like we're going
Mhm.
to encounter people who are struggling with cancer or who have psychiatric problems. And I by hearing how you were feeling and how you processed it, it actually, it speaks to me, and it made me feel a little bit better about the times that I felt that way. And I wondered,
Yeah.
like, why am I, getting so involved in this? Why can't I just leave it?
Yeah. And I think another aspect of the sharing, and I think this is something that you do really well over the course of the book, is that you touch on this. It's not just, the gory war stories where, there's ver variceal blood hitting the ceiling,
Yeah.
um or like maggots and wounds. There's, I mean, in the span of what we do, there's tremendous intimacy and moments of like enlightenment and close friendships and absurdity and humor. I mean, there's just kind of almost a whole range of human experience.
Yeah.
I mean, I can remember so many conversations in our team when at the end of the day, we'd be sitting around and say, like, you can't make this stuff up. I mean, this is the great American, like every day we come in and it's the great American novel. Our patients are such, incredible characters. Like, yeah, I could never, as a novelist, I could never make up the stuff that we get to see.
I think
And
people wouldn't believe you.
yeah,
If you tried to present this as fiction, somebody would go, "Oh, that's so unrealistic. That could never happen." Um,
yeah.
yeah, my husband and I talk about this all the time too. He's a physician also, and
Mhm.
he'll say, "You can't make this stuff up." And I always say, "Yeah, truth is really a lot stranger than fiction."
Yeah. I'm so impressed by novelists who can make up their own world. I've never had been able to sort of, there's too much sort of unbelievable stuff that I've encountered over the course of my life, that to take that, to have to make it up, seems like I'm too busy sort of working with the material that I already have.
I know. Well, and I think about you, like you're a talented poet and a talented nonfiction writer. I'm sure you could write fiction, but it just seems like, well, why would you need to? And I
I,
sort of feel that way too.
I don't know how they do it. I mean, it seems like there's a magic trick that they have that I just never quite got. I was too stuck in reality, but that's an interesting thing. So I wanted to talk a little bit about the structure of the book too, and that you chose to write this in linked essays, and we certainly, I mean, did you start out with the intention of writing a book, or were you just writing essays and they sort of evolved?
Yeah, I mean, I started out with all of this really when we started the nonfiction program.
Hmm.
I had left my, sort of primary care practice where I was everybody's doctor. And I was really, I guess, I mean, burnout is an interesting word because it implies a lot of things, and sometimes it sort of blames the practitioner. I
Right.
was fried though, and it was a
Yeah.
lot of it did have to do with feeling so overwhelmed and ineffectual because I didn't have the resources I needed to take care of my patients a lot of the time. For instance, um, I had a lot of patients who had complex psychosocial issues along with their medical illnesses, or it was hard to even tease apart which was which. I'm not even sure you can make a distinction of what's what in those situations. But I didn't have access to a social worker for my patients who were unhoused. I didn't have, who had food insecurity. I didn't have access to enough mental health care for people who weren't able to pay for it out of pocket,
Hmm.
because there was such a shortage of psychiatrists and psychologists, and most of them are paid so poorly by insurance companies that they, sort of threw their hands up and said, well, I'm going to be out of the system. So I was struggling with all that. And I think also it had just been, I've been doing this for a long time and I was tired.
Hmm.
So that I left, and my intention was to come to the program. In fact, not even a week after I walked out of that office, I started the MFA program, and it was kind of a lifesaver because I just didn't even know what to do with myself. And I think what started happening is I was writing about some of those situations in our workshops, like when we had impromptu writing, I would just, sort of talk about that. Or when I was working on a manuscript, we had to produce 25-page essays or whatever. So I just started writing about it. And some of it got tossed in the trash, but some of it was really what ended up becoming the book. And I never had the intention of writing this book. I had a book published 10 years earlier, and I really didn't even want to do it again. But I think actually one of our mentors, Pam Petro, was responsible for this because during the pandemic, we graduated during the pandemic, and then I'd been talking to her on the phone, and she's like, well, these essays really are sort of forming this arc. You should think about putting them together. And I said, well, everybody says you shouldn't write essays. If you want to write a book, you should write a through story because essays don't sell, blah, blah, blah. So, so I thought maybe I should write a through story. She said, yeah, but you're an essayist. And that is the truth, that the form that I like best and that I tend to gravitate to is the essay. So, I kept writing more of them, and then sort of piecing them together, and in fact did sort of form this arc. So
So
how it
essentially,
happened.
it was Pam's fault.
Yeah, I blame Pam for all of it.
And the time that you had with the pandemic.
Well, yeah, I mean that gave us I think a lot of people were a little paralyzed during that time because it's
Yeah.
almost like, no structure and you don't know how to use the time. But for me, it was more dedicated writing time. I did go to work during that time, but I also had lots of time when I couldn't see my kids or, go out with friends or whatever. So I wrote.
Mhm. So, I mean, you were well established as a writer, but before you came into the program, and I was wondering if you wanted to talk about a little bit about what having that sort of focused experience did for your as a writer, and as sort of integrating as a way of being integrative with your work and your writing.
Yeah, I mean, I was very much self-taught and I'd been to some workshops, but I sort of blew all that stuff off when I was in college. I was doing sciences. I was, I was going to be a biochemist, and then I decided to go to med school, but it wasn't on my radar. Even though as a child, I loved to write. So it kind of, came back around later, but I started writing for real in my 40s.
Hmm.
And what tended to happen is sometimes things would just appear on the page that really worked.
Yeah.
The muse would be with me or whatever. And sometimes, lots of times, it was, pretty much worthy of the circular file. So I was trashing a lot of stuff, and I never really knew. I could often tell when something was working, but I really never knew why.
Hmm.
um, I couldn't reproduce that. And I also didn't know how to fix it very well. I didn't, revision wasn't my thing. I'd really never been taught to revise. So I think that what really made the difference for me, one, was having all that dedicated time to write and to think about writing and to read other people's work and to hear critique. So all of that sort of helped me just feel more like a writer. But I think what I really took away from the MFA was not, that I could necessarily write something, that I wouldn't have been able to write before, but that when something was working, I knew how to use that and I knew how to maybe make that happen again. And when something wasn't working, the MFA gave me a lot of tools to be able to figure out how to solve literary problems, how to solve a
Hmm.
problem of a manuscript. So that was nice. And then it also gave me the privilege of being able to teach other people
Hmm.
because I had the background and more solid theoretical stuff.
That's wonderful. Um, would you like to read another section?
I would. I dropped my book, so my head's gonna like
It's
go away
okay.
for a second. Okay, here we go. So I'm going to read something that's really along a completely different line here, and I think maybe it'll be a little bit more fun. It's really sort of about um, how you can't take the doctor in you out of your personal life, and you also can't take your personal life out of medicine. So this is called Dancing with Death. My dress is bright red. It's lycra, shiny, its bodice clinging close to my upper body. The skirt, though not tight, is too short for my comfort, and it ends in a handkerchief hemline. When I twirl, it flares out dramatically. Underneath the skirt, I wear black fishnet pantyhose. My shoes are gold with a stiletto heel and an ankle strap. The sole is soft leather, specially constructed for the smooth wood floor. If I'd known this would be the costume for the Latin number Larry and I would be performing at the showcase for the School of Ballroom and Latin Dance, perhaps I would have advocated for a foxtrot or a West Coast swing instead. It had been the idea of our instructors, Scott and Christina, to perform a paso doble, a Latin salsa type dance. Scott had acted as choreographer, and Christina had come up with the costumes. Of course, Larry's outfit was much more subdued, black pants and vest with a white shirt. Christina had wanted the red lycra and the fishnets, and I didn't want to hurt her feelings by rejecting her design. Lest anyone believe that Larry and I are proficient dancers on this night, let me dispel that notion right away. We'd been taking dance lessons for only a couple of years, and our skills were quite mediocre. We get the steps right usually. I'm graceful enough after years of ballet lessons as a child and teen, but I don't have the confidence to throw in dramatic head or hand motions, so my style is lacking. For Larry's part, he never quite got the hang of Latin hips, so he's a little stiff on the dance floor. Together, we get most of the steps, but our teamwork needs ongoing attention. No matter our level, all the students are encouraged to perform once a year, and the School of Ballroom and Latin Dance rents out the largest ballroom at the Union League Club of Philadelphia, a venerable institution founded as a patriotic society in 1862. Larry and I call it the bastion of old white men, as the hallways are lined with portraits of its original white male members. Women and people of color were not allowed in the Union League until the late 20th century. Nevertheless, the ballroom is grand and the dance floor massive. Families and friends of those of us performing buy tickets and come to eat dinner, watch the show, and dance during open dance numbers between performances. Larry and I are third on the schedule. We watch the first couple glide by in formal wear, engaged in a foxtrot, before we're entertained by a rousing jitterbug from a woman in a flapper dress and a man in high-rise cuff trousers. When our number is announced, we arrange ourselves in the center of the dance floor with our right hips jutted out and our left knees flexed a bit. The music starts and our body memory kicks in. We flub a double turn, but manage to get back on the right foot and proceed. Our enthusiastic audience, with rather low standards apparently, claps wildly as Larry dips me at the end, my leg high in the air, showing plenty of fishnet-covered thigh. Later, we'll watch the video and laugh at our mistakes and our sometimes awkward movements. No harm, the showcase is always good fun, but for now, we scamper back to our seats to catch our breath. The host announces an open dance Viennese waltz, and a stately older couple, perhaps late 70s, tall and lean and white haired, begins to dance. I notice how beautifully the woman holds her head, the straight line of her back, and how firmly her partner, I assume her husband, guides her. He's a strong lead, something Larry's working on but has not yet mastered. They move together as one, and it appears effortless. I muse at the grace and lightness of their steps. And then suddenly, the man drops to the ground. It happens so quickly and so silently that I almost wonder if I've imagined it. But no, he's lying on the dance floor, catty-corner to our table. And there's now a flurry of activity around him as his partner stands stock still, the serene tilt of her head now gone, her hands covering her mouth and her eyes wide. Larry, who's busy chatting with the man to his right, hasn't noticed this spectacle. Without thinking or saying a word, I leap up from the table and run across the floor. Another guest is leaning over the fallen gentleman who's unconscious. He's breathing, I hear her say hopefully, but I look down and his face is pallid, grayish, and he makes a tiny gasping noise that I recognize as agonal breathing, a reflex indicating that the brain is not getting oxygen, a sign that he's near death, most likely from cardiac arrest or massive stroke. I kneel beside him, yelling, "Someone call 911," as I check his pulse. Absent. I tilt his head back to give a rescue breath and look around to see if someone else appears capable of performing CPR. A crowd is now gathered, and every mouth around me is agape. But Larry's seen the spectacle and is on his way across the floor. I give another breath and then straddle the man to begin chest compressions. Larry moves in wordlessly, and we embark on 2 rescuer CPR. Larry fortunately has the presence of mind to turn to a man next to him and bark, "Go to security and ask if they have a defibrillator." Meanwhile, someone announces they've alerted 911 and the EMTs are on the way. I can't actually say how long all this takes. Time is suspended. After 4 or 5 cycles of compressions, my arms ache and Larry and I switch places. Then an automatic external defibrillator appears and Larry rips the man's already ruined dress shirt off and attaches the pads to his chest. We both move away enough that we're no longer touching him, and I watch the defibrillator box register a wavy line. "VFib," the machine announces. "Proceed to shock." "Clear," I yell and push the red button. The unconscious man jolts. Larry checks for a pulse while I watch the monitor. No pulse. Resume CPR. I give a breath, and he compresses. We move back again. "VFib," the machine announces again. "Proceed to shock." I silently wish for a hospital crash cart, for epinephrine and atropine and an IV to improve the chance of survival, but all we have is the AED, the defibrillator. "Clear," I yell, and push the red button again. Another jolt and still no pulse. We repeat our ministrations. It's the 4th shock, or maybe the 5th, that finally works. There's a spike on the monitor afterwards, indicating a heartbeat, then another and another. "We've got a rhythm," I exclaim. Larry cranes his neck to see the monitor. "Looks like a normal rhythm," he says excitedly. I feel the carotid artery for a pulse, and there it is, weak but present, and I can see the chest rise as he takes a shallow breath. How long has it been? A minute? An hour? No, something in between, maybe 15 minutes or 20. Were our compressions enough to perfuse his brain? And where in hell is the ambulance? Where are the EMTs? As though by divination, 2 EMTs arrived just at that moment, pushing a stretcher, crash box in hand. Larry begins to speak, explaining what transpired, how many cycles of CPR, how many shocks. Well, one of the EMTs checks vital signs and starts an IV line. I stand up from my kneeling position on the floor and register the group standing around us, some of whom, now that the extreme situation is over, are drifting back to their tables. The man's dance partner stands still, silently watching, seemingly frozen in place. "Oh my God, are you his wife?" she says. I see her lip tremble and put out my arms in time for her to collapse into them. "It's okay, they're stabilizing him," I tell her. I know it isn't really okay. The likelihood of someone surviving an out of hospital cardiac arrest is less than 10%, even with bystander intervention. Still, it's as okay as it can possibly be given the circumstances. I turn to the EMT who's writing down what Larry tells them. "Where will you be taking him?" "Closest ER is Graduate Hospital," he replies. "And his wife, will you take her as well?" "No, we can't. We'll need space for all the equipment and both of us to work on him. We have a driver out there in the ambulance. She'll have to come separately." "Are you here with anyone else?" I ask her. "No," she tells me, beginning to cry. "Okay, we're going to take you there. I know Larry will agree, so I don't hesitate. You need a coat. It's very cold out. I'm going to get mine and meet you right by that door." I point to the main entrance to the ballroom. She nods silently as she watches the EMTs transfer her husband, still unconscious, now hooked up to IV fluids and a heart monitor, oxygen tubing in his nose, to the stretcher. They start moving the stretcher towards the door. She inhales sharply and turns to get her coat. Larry goes to get our car from the parking garage, and I lead the woman, who's now teary and limp, down the steps and out to the street. Graduate Hospital, which will close as a full service hospital just a year later in 2007, is only 6 blocks away, but the traffic makes the trip slow and plodding. The time allows us to introduce ourselves. She is Mrs. P. We tell her we're physicians and try to calm and reassure her. She thanks us repeatedly, and we demur. "It's just what we automatically do," we say. In fact, it was completely automatic. We'd been so thoroughly trained to recognize emergencies, to step in and take charge, to follow the protocols, that we couldn't imagine doing otherwise. It was as though the flowchart for emergency procedure appeared in front of our eyes, and we carried out the steps without thinking. There'd been other times I'd needed to perform CPR outside the hospital. There was the woman who'd collapsed right in front of me in the Philadelphia airport. I was holding my year-old son and had to hand him over to an airline agent while I tried to resuscitate her. 2 years later, 8.5 months pregnant with my daughter, I entered a friend's apartment building to find a woman screaming for help in the lobby. Her husband had been pulseless on the floor for more than 5 minutes. She didn't know how to do CPR. I'm pretty certain he was beyond help by the time I started resuscitation. As far as the woman in the airport, I never found out what happened, but my best guess is she didn't make it. Arriving at the ER, we park in the emergency lot and usher Mrs. P through the ER doors. It's bracingly cold outside. I haven't taken the time to close my coat, but I clutch the front panels together to stay warm. I haven't been in graduate's ER for over 20 years at that point, but as a medical student, I'd done my general surgery rotation at Graduate, and I feel a spark of recognition even all those years later. I take Mrs. P's arm and lead her to the reception desk. "This is Mrs. P. Her husband was brought in by ambulance probably just a few minutes ago," I tell the nurse. "Oh, yes, just a moment. I'm going to get the doctor for you," she replies. We sit on beige vinyl chairs in the stark and empty waiting room. She holds herself stiffly, her face now stoic. I wonder fleetingly how it would feel to be waiting to hear if my husband, the man who not an hour earlier was my dance partner, gliding me across a shiny wood floor in a ballroom, is alive. Then I shake off the thought. "Mrs. P," a male voice reaches us, followed by the man it belongs to, a stocky man with tired eyes and graying temples and green surgical scrubs and a white coat. "I'm Dr. Smith. Your husband is stable. It looks like he's had a heart attack, and the cardiologist is in there with him right now. They want to take him to the cardiac catheterization lab. You know, he was really lucky. Most people who have a cardiac arrest like that don't even make it to the hospital alive." "Well, these are the people who saved his life," she tells him, gesturing to me and Larry. I feel myself flush. I'm not yet sure that he was saved. He could die in the cath lab, or maybe he's already brain damaged from loss of oxygen. "Why don't you go join your husband?" Dr. Smith says. "I'll get some information from these folks." "Yes, please," she answers. She thanks us again. Before she walks through the door to the clinical area, Larry slips her his card. "Let us know if there's anything we can do for you." And then she's gone. Larry and I stand facing Dr. Smith. "So what exactly were you all doing when Mr. P collapsed?" Dr. Smith asks. I notice he's directing his question to Larry. He makes no eye contact with me and seems to be subtly smirking. Dancing, says Larry. Dancing, repeats Dr. Smith skeptically. And how is it that you people know how to do CPR? Now he looks at me. In fact, he looks me up and down. I glance down at my feet and see the gold stiletto heels, and it hits me. I'm standing in an ER waiting room, my coat hanging open, in a red lycra mini dress and fishnet stockings. I'd done CPR in a red lycra mini dress and fishnet stockings. At a ballroom dance showcase, nobody would think twice about my attire, but in the ER, well, it's incongruous. I was so intent on handling Mr. P's emergency that I hadn't thought for a second about what I was wearing or how we, well, mostly I, must look standing there. Well, actually, I blurt, we're doctors. I know we look kind of strange, but we were in the middle of a dance performance, and the whole thing happened right after we finished our salsa dance, and my voice trails off. I imagine he thinks we're either crazy or we're lying, but really, who cares? Truth really is stranger than fiction, I think to myself. Dr. Smith works in an ER. He should know that by now. What difference does it make anyway? What if he thinks I'm a hooker? What if he thinks I was entertaining Mr. P when he had a cardiac arrest? What difference does any of it make? Okay, if there's nothing else you need to know, we're going to go, Larry says, and we head for the door. We return to the dance showcase. We've left our street clothes there at the Union League Club. Besides, there are 2 more hours of performances scheduled, and we think we want to watch. But when we get back there, I can't keep my mind off Mr. P. What's going to happen to him? Is Mrs. P okay there by herself, waiting for her husband to come out of the cath lab? Strangely, when we enter the ballroom, a few people greet us, but nobody comments on Mr. P's collapse or asks about the resuscitation. Everyone is busy eating and drinking, talking about the dancers, watching the performances. They've all moved on already, but I haven't. I look at Larry and we lock eyes. I don't want to stay, I tell him quietly. Neither do I, he says. I can't get back into it. Let's go home. We don't talk about it anymore. There isn't anything to say. We both just need to process the events of the night. Like so many times, our pagers went off during family dinners or in the middle of sleep. We were pulled abruptly out of the non medical part of our lives and into someone else's drama, into their intimacies, their complications, their tragedies and traumas, their near misses. And once you're pulled in, it isn't always easy to walk back out. Your mind lingers in the whys and the what ifs, the realization that someday this could be your own tragedy or trauma, or if you're lucky, your own near miss. It was not my life that was altered that evening. Our lives remain on the outside unchanged, but everything looks a little different on the inside. We get a call from Mrs. P a few days later. Mr. P, she tells us, has survived not only the catheterization, but also a subsequent triple bypass surgery. He's still recovering in the hospital, but she expects the doctors to discharge him in the next day or two. His brain, she says, seems unharmed. It's almost miraculous, completely against the odds. A few months will go by, and Larry and I will stop going to the School of Ballroom and Latin Dance, our lessons becoming a casualty of our too busy lives and the priorities we've set. We will have learned enough to dance at bar mitzvahs and weddings, to pull off a rumba or a double step, though the choreography and rhythm never become true second nature. After the showcase, whenever Larry and I dance, I'll think of Mr. and Mrs. P. I'll envision their graceful teamwork. I'll relive the split second in which Mr. P stopped being Mrs. P's graceful dance partner and the moments in which he almost died. I'll wonder if they ever had the chance to waltz again.
That's such a beautiful story, and it covers so much ground, you know, from the absurd to the sublime to the
It's ridiculous, yeah.
yeah, yeah, and just there's some wonderful self-reflection in there. I want to encourage people. There's still some time maybe for some
Yeah.
questions from the audience, and so if you want to drop them into the chat, I can look them up. But and while people are doing that, I love that. I just love that's such a good story that encapsulates so much of what people do, but both in in and out of practice. Having that awareness of human experience, and you
Yeah,
write
sort of
about.
like instinct. Like, haven't you
Yeah,
Ever
yeah.
stopped on the side of the road when something's
Oh
happening?
yeah, no, I was on a flight. I was on a flight just last month, and the call goes up. Like, are there any medical people on the board? And you're like, oh geez, what are we getting into? And it wasn't a bait. It was a woman who had fainted, and she was
Yeah.
okay. But it's like you never know. Um, but I was thinking about I was thinking about the chapter the essay that you were, there was sort of an open letter to a patient,
Oh
uh,
yeah.
the one where you're really sort of being very transparent about the complexity, the emotional complexity that you have in trying to deal with her really intractable pain, and not being able to 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 make her better, or to alleviate
Yeah.
her condition a lot. But there's a quote on that which I'd love to cite here. It's you sort of towards the end, you say, "My job is not to make you whole, but to be as whole as I can be, to heal you with my own wholeness." That sort of relational thing, that when things aren't ultimately resolvable, like this human element is still important in that. Um,
Yeah,
and
it's the whole idea that we can't necessarily cure things,
mhm,
um, or change the course of an illness. But that doesn't mean there can't be healing, that even, even in a terminal situation, or even, with a family after someone's died, there can
mhm.
be healing. And that's a totally interpersonal thing. And it's like we forget that, especially with the fast pace. And, we're in the electronic medical record and Epic, and we're pulling up diagnosis codes, and, coming up with all the drugs we can use, and we forget that, like, this is a person who really needs another person to sort of catch them while they're falling.
Well, I think about it just in the story that you just told with Mrs. P. I mean, you could have just gone back to the dance party and sort of left her to her own devices. But I mean, you saw her in that movie. That was the most human thing to do, would be to be a present to her, even though her husband's outcome wasn't clear, to be present to her as part of that whole situation. I think it's really wonderful.
Yeah, and that, and it's certainly, like, I would never leave that situation. There are a lot of people who would, and sometimes, though, I wonder, like, is that one of the reasons why I suffer more than I need to? Because I'll always be right in there, and, I take on other people's stuff. It's a complicated thing. You have to have, like, some kind of a happy medium.
Right. Well, this kind of there's a question here from Julia, actually, and I'll just read it. Rosalind, you do a remarkable job balancing the, as your title says, magic and misery of being a physician. When you were choosing the topics for these essays, how did you maintain that balance of the more positive memories without losing the harsh realism, and the negative ones without getting too bogged down by pessimism and despair?
Oh, that's
It's
a
a great
great
question.
question, Julia. Of course, you would come up with that. Well, I'm not sure that I planned that. I think that things kind of write themselves when it comes to something like that. Like, I wrote these essays, and part of it was I was seeing the theme of, this makes me so miserable, and I can't do this anymore, but also I don't really want to be out of it because I'll miss all these other things. So that sort of happened, and I realized that this is what this book is going to be about.
Hmm.
Um, as far as, like, not getting bogged down in, sort of the despair and all that, that's distance. That's, writing from a distance. And I like you talked about, with your brother, um, I can't write about a lot of things right away after they
Hmm.
happen because I don't have any perspective. And I need that, tincture of time to sort of let it brew a little bit, and then I can start writing, and I'll sort of figure out even more as I go along with the writing. But I think that's why the writing doesn't have all the despair in it. Believe me, there were days of my feeling lots of despair.
Mhm. Well, there's some really long, I think the longest essay in the book really sort of, you really take a long look at sort of the medical system and
Mm.
how it's really been failing us both as consumers, as patients, but really, I mean, uh, even more so as clinicians, and the toll that's taken on you personally, but as you see really on your whole profession, as it becomes more and more um, monetized and impersonal, and it's I mean, and it's interesting to read the argument, and there's so much of that, and then at moments that there's sort of pokes at, there's bits of humanity, or certain encounters that sort of poke through that sort of dreary narrative, that draw you back in, or you find ways back in by, working in the urgent care center, or finding ways to balance your time, but there's always that draw to sort of have that human connection. I thought that was really interesting.
Yeah, I feel like I can't completely give up my stethoscope, and
Yeah.
I found other ways to be in it. I don't want to go back to doing primary care, and I feel a little bad. I mean, I've always felt a little bad about that because there's a huge shortage of primary care now, and that's the result of the sort of way that the system is geared to um, treating those who do expensive procedures and make money for the hospital differently than they treat the people who are just, the run of the mill first line doctors who see the patients. And that's driven so many people out of wanting to do that. And yet, without that, it's just going to get more and more expensive. People can't find a primary care doctor to deal with the little things that come up, so they have to go to a GI specialist for a stomach ache, and a neurologist for a headache, and that really shouldn't be true, and yet that's what's happening.
Yeah.
And it's getting worse over time. I mean, the pandemic did a lot to that situation too, but it's been happening for, that's how it's sort of been going for a long time.
Yeah, I love how you talk about spending more and more time in front of the computer screen and less time facing the patients, and how the need to document, and document, very specifically, has taken over more and more, and that I can relate to that so much. There's that wonderful passage where you're talking about the ICD-10 codes, which are the
Oh God.
which
Yeah, I
are
mean that just gets very silly, that one
yes.
too, but it's true. I mean, there are codes for sucked into a jet engine,
Oh,
initial
I
encounter and subsequent encounter. I'm not sure you could have a subsequent
can
encounter
count
if you
it.
were sucked into the jet engine.
I went to a coding training once where the instructor was just so excited. He said, "Yes, and we even have there's a code for physical injury sustained when attacked by a duck."
Yes.
Yes, and she was so proud that they had that covered. It was like,
Yeah, they have everything covered.
yeah,
But what's the purpose of these zillions of
right,
codes?
yeah. As opposed to sitting with
Yeah.
somebody when they're,
Yeah.
I mean, and yeah, and I mean, I know most of the people that I dealt with they had so many layers and layers of, physical issues, and childhood trauma, and substance abuse and everything. You can't just tease out the codes. I mean, people are complex, and
Yeah, and we know that, for instance, bad socioeconomic situations lead to physical disease. I mean, there's inflammation from that, and then there's diabetes, and there's hypertension, and there's all kinds of other things. And we're trying to act as though all of these are separate problems. So we're not going to deal with, you know, society's ills and the fact that there are people living in terrible poverty. We're just gonna like make more medicines so that we
right.
can treat your diabetes.
Right. Or we're going to suture, the cut on your finger because we can do
Yeah.
that, and then send you home. There's another comment from Walter Tsu, who says, I think the real value of writing these essays is that most doctors only give a minute version of these traumatic events that they tell others in abbreviated fashion. Writing it out allows one to fully relive the event because the details are vivid and allows others to experience what it is like to be a doctor.
Yeah, I think that's true when something's well written.
Mm-hmm.
It's just like, yeah, it's just like when you watch a really good movie about something, you know, that you're really, it's like you're in it and
Yeah.
you can experience it vicariously. And so that's certainly, you know, what I would go for. Yeah, that I would want to be doing.
Yeah. Yeah, and you have many details like that in your stories about that sort of give that window. I was thinking too about television. You know, The Pit, which we were talking about recently. One of the details that I really loved about that was that the main character, the Noah Wiley character, the start. Every time he walks in a room, he's really fastidious about sanitizing his hands, and over the course of the, I mean, the whole thing takes place over a day. Over the course of the day, he becomes less fastidious, and toward the end, he's just racing around as things become more chaotic. But I thought that was a detail that they among many others that they caught very well.
Yeah, and such a you know an important detail because it's so much a part of what we do is like got to make sure that I'm not bringing germs into this patient's room, and then it
Yes.
does become less and less important when there's more chaos around, and you know, yeah, we're human.
Yeah, right. Yeah, we do our best, but there's all these things that can get in the way. Um, is there anything in particular that you would really like to emphasize about this book or about your process in writing it, or that you'd like to share with people?
I honestly, I'm just so grateful that people who have read it have found something in it to speak to them, and that's really what I wanted to do most. I mean, I think when in writing memoir, um, the whole idea to me of writing memoir is that it makes us feel less alone. You know, it makes
Mhm.
us as writers feel less alone to be able to put this stuff out there, and hopefully readers will, you know, come to it and say, okay, this is another person and I'm connecting with this person, and then they feel less alone too.
Yeah. Well, I think you really did a wonderful job of bringing your whole self into the memoir, and I mean your best badass self, which you could be on some days, and then the times when you were really sort of questioning whether it was sort of an externally imposed sense of like you're not good enough, or where there was as an internal thing, and sort of struggling and refining yourself. And and just all the vignettes, like your husband proposing to you in a storage room.
We love that story in some ways, and then I look back at it and I'm like, wow, I mean,
Wow.
could have had a real proposal, like, you know,
Yeah.
somewhere pretty with the ring and all that. Um,
But
yeah,
yeah,
but it
but
was us.
it was, yeah, and it gave such a good sense of the both of you, and what you became together. And that was good. And I love that very close to the end of the book, you talk about it, the tattoo that you have, um,
Yeah,
which is, which it's a saying. It's and I didn't write down the author, but it's, without hope the heart would break.
yeah, yeah, and I mean, we all have to have hope when there's an illness, and um, to me, the hope is, you know, of someone recovering, but also of some kind of healing and some kind of growth through whatever happens to us. So
Yeah,
um, I think that if you, you know, if you give up hope of something coming out of it, you do end up brokenhearted.
yeah. I think I think we tend to mix up being cured with being healed. That those are two very different things. And I think in this book you really show a path towards being healed. Even though it means not, you're bringing some of your scar tissue with you,
Yeah.
um, but that you're able to move forward in relationship, and to the forces around you in some way, and that's a real testament.
And I feel like we're the reason I like the title, not necessarily the subtitle, which I was a little bit goofy, but the title's still healing, because I feel like, yeah, I mean, part of it is, yes, I'm still practicing my profession, but I feel like we're all always sort of healing from something,
Right.
and if as long as you're moving forward, that's a good thing.
Yeah. Yeah, and forward may not necessarily be the clearest path, but
Yeah.
it's somehow it's forward, even if it doesn't seem like it at the moment.
I just want to say thank you, Robbie, I mean, you did such a nice close read, and as always, you're very astute about things. So I really appreciate this conversation.
Well, it was a page turner too. It was like I was like, wow, these are. I mean, some of the stories I knew from workshop, but the ones I didn't were like, oh my God, these are wonderful, and they're it fits together well. So everybody should buy this book and enjoy it. It's a revelation.
All right. Well, thank you so much for that phenomenal discussion, Rosalind, for those incredible readings. I'm wearing a Fitbit, so I can confirm my heart was racing when you were describing giving CPR. So that
Oh,
really just speaks to the incredibleness of your prose and how you really bring the reader into the moment there. So thank you so much for that. Thank you, everyone, for attending this launch, for the kind comments in the chat from Rosalind. I dropped the link again. Don't forget to go out and order the book if you haven't already. And thank you all for being here. I appreciate it so much.
thanks,
Thank you.
Julia. Thanks, Robbie.
Thank you. This has been wonderful.